So you might get a pop-up that asks if you are okay being recorded, and we hope you'll stick with us so that we can make this presentation available afterwards. So again, this is being live streamed to Facebook, and we will monitor the comments there, as well as anything that comes through the chat or question answer here on Zoom. So thank you for joining Mental Health, Law Enforcement, and People of Color. So our primary speaker today will be Kirsten Velez. She's a licensed master social worker. She works in the Greater Access and Partnership Program, or GAP for short, as our coordinator case manager. And she will be presenting on a whole lot of information that we hope you will find useful today. And that you'll find relevant, and we encourage challenging questions and discussions so that we can learn and grow together. The person who's talking with no video, that is myself, Anastasia, or Stas Taylor for short. I'm a licensed clinical social worker supervisor. I'm the CEO and founder of Alliance Child and Family Solutions. And for those that are just joining us, normally I would have video on, but I have been at urgent care all night with kiddos. So I appreciate your grace in that aspect. And I've also roped in Dr. Brian Dixon, who is one of our board members at ACFS. They can't really see you unmuting, so you may want to unmute and say hi real quick.
Hey, good morning, everyone. Thanks so much for being here and for doing this all on Zoom. We would much rather do all this stuff in person, but you know how that goes. So hopefully this is super helpful to everyone today.
Perfect. So again, we are your presenters for today. And let's see here. Just to give you an overview of who we are and why we're doing this. So we as Alliance Child and Family Solutions are able to host these workshops, thankfully due to the Fund to Advance Racial Equity at the North Texas Community Foundation. They have allowed us to do a number of workshops to make this possible. Now, what does that have to do with ACFS and mental health? I mean, obviously we have a little mental health side note here for our theme today. And while our goal as a 501c3 nonprofit is to make life-changing mental health services affordable and accessible for all Texans, the reason we think these workshops are so valuable is because we cannot treat the symptoms of mental health that come when there are such huge structural inequities, discrimination, and racism. So these are not mentalities for people to change or for our clients to change, but something that we believe is important to educate and advocate so that we can be the difference and hopefully help reduce that trauma from even occurring in the first place. So that is why it's a big deal and why it relates to us as a counseling agency. Now, there are a couple of you that signed up for CEUs, and we will give some information at the end for how to go ahead and take those credits. And so a couple disclaimers, just so that you know of any conflicts that we may have. So we are a 501c3 nonprofit. So as part of our introduction and discussing the ways that we do promote advocacy, you may hear about our specific programs and services or how to support our mission. It is focused by any means. Some housekeeping stuff. We will be watching Facebook and Zoom for any of your questions that come up. So I actually hope you guys will drop in the chat, tell us where you guys are viewing from and maybe how you heard about this workshop or ACFS, just so that we can get connected to you guys, because we hope this will be an interactive seminar here. So that said, one other housekeeping thing that's very important. We hope that this will be a safe place for all those that are attending, where you can have an open conversation. And while we are discussing statistics, facts, historical events, and ethical codes, things that we think are objective and structured in nature, that does not mean that it's not difficult. So if you have been part of a marginalized population, you've experienced past trauma relating to mental health, law enforcement, or even your experiences as a person of color, some of these things may be difficult. And so that's normal. So we want to put that out there and hope that if you need to take a deep breath kind of walk away for a second and regroup, or send those questions to us privately or anonymously, you can do that. So these are all really important as we talk about what we're covering today. So lastly, so the objectives that we will cover is statistics and challenges regarding mental health and law enforcement. We will also talk about some of the current challenges that are faced by mental health and law enforcement systems, and then exploring our ethical responsibilities as mental health professionals, as well as individuals in the community in advocating for change. So thank you to those who have posted in chat, either live or directly to us, where you guys are attending from. It looks like we have some amazing people from out of state. We see some Illinois. We also see, hey, Women's Center of Tarrant County. So excited to see you guys there, Pennsylvania. So we are just floored that you guys are joining us. So I would love to hear more about how you heard about this so that we can continue to connect with members of the community. So I am, going the wrong way for one, but for two, I'm going to hand it over to Kirsten, and I'm going to mute myself so she can tell you and just get started about mental health and whole.
Yeah, so I just want to start. I realize we're covering kind of three very broad and heavy topics. So I'm going to break it down a little bit and kind of go section by section. And then at the end, we'll kind of relate it all together. So it makes sense that way. But I just want to start off by saying kind of why we started this topic and why we believe that it is so important is because we realize, especially in our community, that once an individual in a mental health crisis is stabilized, whether that be a hospital, emergency room visit, or a jail, that there isn't a system to connect individuals with resources to prevent duplication of services or repeated crises escalating to law enforcement. So basically, that means that police are asked to serve outside of their capacity to help those with mental health concerns. That's essentially not their role, but that's kind of what they're having to do. So that's why we have created our program, and which we'll discuss later. So I think in order to best explain how we kind of as a community got to this point that we are in now within mental health intervention and kind of the lack of the resources and the interventions after a crisis that are there now, I think it's important to kind of start from the beginning and dive a little bit into the history of people of color and mental health. So in 1848, John Gall, a physician and medical director of the Eastern Lunatic Asylum in Williamsburg, Virginia, stated that Blacks are immune to mental illness. He also hypothesized that enslaved Africans could not develop mental illness because as enslaved people, they did not own property, engage in commerce, or participate in civic affairs such as voting or holding office. And unfortunately, theories of these continue to go on even through the 20th century. And medical researchers at the time promoted conditions such as drapetomania, which they stated was a disease that caused enslaved Blacks to flee their plantations. Concepts such as this went as far as to be listed in the Practical Medical Dictionary as late as 1914. And as medical studies were done and research was updated, it was, obviously found that these concepts were essentially made up concepts and untrue. However, concepts such as these had and will continue to have kind of effects on people of color in the mental health field. So next, we just have a little video to show you, just kind of going over the impact of discrimination, racism, and then police interactions on
So I've talked
mental
about
health for people of
segregation
color
as an institutional mechanism of racism that has consequences for health. But it's also individual level discrimination that also matters for health. I began with an example of individual discrimination that came from what's called an audit study. An audit study is one of those studies when we hold everything's identical and the only thing we vary is race, and we look to see what happens. And that was true by the researchers at Portland State University and put in black and white males dressed similarly. The only thing that varied was their race. There are high quality evidence, there is high quality evidence from audit studies documenting discrimination in all of these domains I listed on this slide, and this is not all of them. There are a lot more. I could entertain you for the next hour just describing these specific studies of how pervasive discrimination is in American society. But I want to talk about a subtype of these experiences, because not all the experiences of discrimination is someone even aware of. But what about those times when you're treated differentially, treated badly, that you are aware of? Martin Luther King said that discrimination is a hellhound that gnaws at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as the truth in the society dominating them. If this is true, and it's a hypothesis that could be tested, then it's plausible to think discrimination could have negative effects on health. This is a study from the American Psychological Association using measures of discrimination that I developed. Showing you one of the, I'll show you two slides from it. One of them is about discrimination from the police. This national sample, this is the data for men only, were asked, have you ever been unfairly stopped, searched, questioned, physically threatened, or abused by the police? And you could see African Americans report the highest level. 39% of all African American males said they'd have that experience. One of the study that was published in the Lancet earlier this year in May with Jacob Bohr and some of his colleagues and myself, we documented for the first time that police shooting of unarmed African American males led to worsening mental health of the entire Black community in the state in which that shooting occurred for the next 3 months. Linking two data sets, a data set on police shooting and a data set on mental health at the state level, we were able to document that pattern. So these events are not just random events that occur, they are literally impacting mental health. But interactions with the police and discrimination are big events. The measure of discrimination that I have developed that has shown the strongest negative effects on health is one that's called the Everyday Discrimination Scale. It just captures little things. In your day-to-day life, you're treated with less courtesy and respect. You receive poorer service than others. People act as if they think you are not smart, or if they're afraid of you, or if they think you are dishonest, if they think they're better than you are. A lot of little indignities.
So Kirsten, break it down for us. Why is that video relevant? Obviously, we have the information about police shootings, but what does that have to do with mental health? What did you see most in that?
Yeah, so I think the most important thing to note was that one of the things you stated was that unarmed Black shooting affects the mental health of every African American in that state. So you can see that the interaction with police directly affects the mental health of people of color. And it's important to note, I think, that not only are people of color fighting back from earlier stigma within the mental health system with what we talked about previously, but they're continuing to fight against current discrimination that continues to have an effect on their mental health. And it's also important to note that I think it's noted a different time in this video, but discrimination predicts higher levels of any 12-month DSM-4 psychiatric disorder, and that this is a worldwide phenomenon. There have been studies that have been conducted regarding this in the United States, in Africa, and in the United Kingdom. And those are definitely studies I can pull up and send out later if that's something that you guys are interested in.
Keep that statistic again, because I think it's shocking to hear how high the rates of mental health are. So say that one more time.
Yeah, sorry. That discrimination predicts higher levels of any 12-month DSM-4 psychiatric disorder, and that is a worldwide phenomenon. So continuing discrimination will continue to have an effect on mental health.
And Kirsten, if I can jump in real quick. So one of the things, and this is just in the work that I do, so to everyone in the workshop, I'm a child and adolescent psychiatrist here in Fort Worth, Texas. So I have a private practice, but I've worked in multiple domains. So I've worked in community mental health. I've worked in big multi-specialty group practices. I've worked in the jail system when I was in residency, and I'm actually contracted with a youth facility now. And one of the things that I hope we take away from those statistics is that, much to the point of the guy in the video, is that it has been proven now, using the data again and again and again. And the question is, what do we do with that? So our first responsibility as just people and citizens living right now is to recognize that, yes, we have now proven that it happens and it's awful. And to Stas's point earlier, it's not, it's a systemic issue, but there are individual things that we can do about it. And that's what we will drive that point home as we go through the conversation. So thank you, Kirsten. I will be quiet now.
No, of course, feel free to jump in anytime. Next, I'm kind of move to the relationship between the mental health and law enforcement. So the national number of mental illness, it is reported that around 61.5 million Americans will experience mental illness at some point in their life. And in regards to that, with engagement with law enforcement, 3 to 6% of law enforcement encounters involve those with mental illness. So that means that is anywhere from 184,500 to 369,100 people with mental illness that may encounter law enforcement. And unfortunately, the results of those involvement is that can be detrimental. In 2015, the Washington Post conducted the first ongoing tally of officer-involved shooting deaths of the mentally ill. Nationwide, at least 25% of those people who were shot and killed by police officers suffer from acute mental illness at the time of their death. So that means that people with untreated mental illness are 16 times more likely to be fatally shot during an encounter with police than people with their mental illness under control. And unfortunately, stories that kind of go along those lines are stories that we are reading and hearing in the news all too often. Some names such as Ricardo Munoz, who suffered from schizophrenia. He was unfortunately shot and killed by an officer when he was in the middle of an episode. Walter Wallace Jr. was also in the middle of a psychological episode when he was shot by 2 officers in a street. And then Atiana Jefferson, she was local to where we are in Fort Worth, Texas. And on October 12th, 2019, she was shot and killed by police in her own home. A local neighbor was concerned when seeing the front door open at early morning hours and called for a wellness check. Body cam footage shows that the officer shooting Atiana through a window without announcing his presence, and all she was doing was playing video games inside with her nephew. And I mean, those are only a couple stories out of, unfortunately, hundreds. But I think it's important to continue to acknowledge that when we hear the stories and look at the articles, that there is, a higher percentage of minorities involved in these encounters. Overlooked and undercounted, and the role of mental illness in fatal law enforcement encounters. Because of disproportionate volume of contact between individuals with serious mental illness and law enforcement, reducing the likelihood of police interaction with individuals in psychiatric crisis may represent the single most immediate practical strategy for reducing fatal police encounters in the United States. So since most officers aren't properly trained on how to be a mental health interventionist, they are going outside of the scope of their job when responding to many mental health calls and crisis. And so instead of asking the officers to work outside of their scope and their job, we believe that to have another intervention plan or an intervention person in place to reduce the interactions with the officers will then in turn reduce, unfortunately, some of the fatalities that are being seen when it comes to interactions.
And this is Stas. I'm going to jump in and just say, while these are very, very difficult statistics, and they're not statistics, they're stories and they're people's lives, and there are families and communities that are affected. This isn't a statement against police, because if you are having a heart attack, you're not going to call an electrician. So why is it that when we're having a mental health crisis, we're calling police when that's not their role? So again, part of the reality in this is we have changed structures and systems to put police in an impossible role that makes it a lose-lose situation. So there are things that can be changed, and we'll talk about the role of police and what's within their scope. But I think it's also important to note that while they may be the ones behind the gun, again, not all police are bad, and this isn't a statement against them. I think these are ways that we need to change the entire structure of things.
And I piggyback on that. These are very difficult discussions. I have family members who are in law enforcement, and we have very robust conversations every time we get together, especially because they are Black men serving in law enforcement and Black women serving in law enforcement. And to Stas's point, so this is a unique opportunity for the mental health world to come up with some solutions, and then to have law enforcement as our partners, as our co-creators in building something new. Because what we do know is, looking backward, there are some gaps, which is why the GAP program exists, plug. But there are some gaps both in the mental health world and the law enforcement world. So this is a unique opportunity for us to come together to figure some things out.
Yeah, definitely. And just the general barriers to care in regards to mental health, what challenges do people of color in the community, what do they face, and kind of why are we seeing not their mental health not as frequently being addressed? I know there are definitely way more than three, but I just kind of listed the three most that I see most common in my practice, and I've seen kind of heard across the board from other colleagues and such. So the first one is cost, and I believe that, this is really one of the biggest barriers, I think, in regards to, weekly counseling, medication for potential psychiatric disorders, anything along those lines. If you're doing this weekly and you're taking your medication every day, the costs of these things can, add up to hundreds of dollars a week, which is just, money that some people don't have. And then on top of that, if, someone is suffering from a psychiatric break and the, last case scenario is to send them to the hospital or the emergency room. In Texas, at least, the average cost of an emergency room visit can be up to roughly $2,000 without insurance. And that's just something that isn't, sustainable for many people, really. And so the next one I wanted to discuss is the availability of resources. I think we've been super fortunate here to have free and low income resources available to our clients. But however, facilities that are providing these mental health services just really don't have enough capacity and aren't big enough in capacity to take on the demand. And that's just what we've been seeing with where we're at here. And then
let me hop in 1 second.
Okay.
When we talk about resources, I know our focus is on mental health treatment and resources, but if we take a couple steps back, I know one of the things that you've mentioned that you faced a lot is, here we are trying to help individuals with basic needs, and we're going out and we're evaluating housing and food and basic resources. And because the needs are so great, there sometimes is not help, especially for unique situations. And so then you have individuals lacking basic needs, housing, food, ability to even get care, any of those things. And now that's triggering mental health crisis. So while there is absolutely a shortage of providers in Texas, in fact, they've done a full basically committee to try and address how few providers there are and how little care and how disconnected things are. We also need to realize that the lack of resources includes basic care.
Right. And it's hard to address a mental health concern or a mental health crisis when your basic needs aren't even being able to be met. And the last kind of challenge that I've seen, especially in communities with people of color, is just the stigma that comes and surrounding the mental health. Because of the stigma, unfortunately, it causes a lot of people to not seek out any form of treatment. And I think that, we as providers, caregivers, like social workers, therapists, whoever are here, that we kind of need to help make it a part of our responsibility to open up the conversation and to kind of encourage the equality, like I was saying, between, mental wellness, physical wellness, basic needs, like all of these things need to be met in order to best have the discussion of mental health. But I think that, as we try to come up with ways to openly discuss that with our clients and the community, I think it's important to continue that conversation with other practitioners and stuff as well.
And one of the comments that came through to us as panelists said, it's been their experience that, sometimes individuals in the public that do have serious mental illness. And so when we refer to serious mental illness, we're talking about kind of the very extreme psychosis, the schizophrenia, the bipolar, the mood changes that maybe are not things that individuals see on a regular basis in their daily lives. That sometimes the public views these individuals as violent and dangerous, even though the belief is not supported by statistics. Or they see family members that are calling the police to help take their loved one to a crisis facility. And I agree. I think one of the things that's difficult is, as you see from this slide about access to care in Texas, at least from my experience, those of us in mental health have always kind of had the giggle of like, yeah, we know we're at the bottom of the barrel, but we're 50 out of 51 when it talks about the contiguous United States and territories, looking at where we stand for how we can access mental health care. And so that included what insurance availability do we have there, what special education, workforce, all of that. And so this, we can kind of loop back around to it, towards the end of the presentation, but there are not intermediate options. And so families, out of lack of knowing where to call, because so many have had to call a list of 20 places with no help, they call the police because they're kind of out of options and resources.
Yep. And to piggyback on that, so I trained in Kentucky, and I see there was someone in the workshop, I think from the Atlanta district office. So that's kind of awesome. So different states do it differently, and as Stas just pointed out, different states spend their mental health per capita spend is different. And in Kentucky, it was much different. It was very different, and so. We had a lot of intermediary resources. So there was a step or two or three between you being in my office and you being in jail or you being in the hospital. We had lots of intermediate steps that Texas unfortunately doesn't have. And so this is a great opportunity for if y'all are out there and you're listening and you are in the chat, or if you're watching this later on, shoot us some ideas of what your state is doing or what your localities are doing. Because this is a great opportunity to just share those ideas and get some cross-pollination, because from the Texas perspective, things are really dire.
Yeah, definitely. And something that I was kind of discussing as well is that I unfortunately had a previous client who had their son suffering from a mental health, and she didn't know what to do. So she finally went through the courts and got a mental health warrant, and her son was forcibly removed from the home and put into a psychiatric hospital. But because of the son, being of age, he was released the next day and wasn't put in a hold. And so, I mean, like you were talking about like a way to safely transport individuals, I think that would be a good kind of intermediate as well, instead of, being forcibly removed from your home by police officers when you're in the middle of a mental health crisis. But to kind of bring it all together a little bit, and why we've been talking about all of these topics, is just simply that African American adults are 20% more likely to experience mental health issues than the rest of the population. And I mean, this relates because, if we put together all of the ideas we've discussed, if African American adults are 20% more likely to experience mental health issues than the rest of the population. And like we discussed earlier, at least 25% of people who are shot and killed by police officers suffer from acute mental illness at the time of their death, then I mean, by those standards and statistics, and unfortunately, African American adults are more likely to have a fatal police encounter just because they suffer from mental health. And like Brian discussed earlier, you know, these are statistics and stuff that unfortunately are familiar and have been brought up a lot of time. But I think, you know, as we continue in this presentation, it's important to discuss and like advocate potential ways to change and enact change. So we're not just discussing these statistics, you know, over and over again, but we're kind of putting in real life interventions and stuff to hopefully help reduce those statistics as well. And so advocating for change. So how does some of our mental health codes compare in regards to what we've been discussing? So as far as social work ethical standards go, you know, in the ethical standards, there are three main points that I looked at to kind of go over and discuss our role in advocating for change in this area. So the ethical standards to clients, to professionals, and then to the broader society are the three that I focused on the most. And so it seems like a lot. I'll break it down really simple. But the social worker's ethical responsibility to clients under 1.05, cultural competence and social diversity. It just states that social workers should understand culture and its function in human behavior and society, and recognizing the strengths that exist in all cultures. Social workers should have a knowledge base of their clients' cultures and be able to demonstrate competence in the provision of services that are sensitive to clients' cultures and the differences among people and cultural groups. And social workers should obtain education and seek to understand the nature of social diversity and oppression with respect to race, ethnicity, national origin, color, sex, sexual orientation, age, marital status, political belief, religion, and mental or physical disability.
So before she gets on to the next one about discrimination, because I kind of flip-flop back and forth for where exactly to kind of put this slide, but one of the difficulties when we speak about cultural competence and that it is in our ethical code that we understand oppression. We have this kind of weird thing in Texas where what has been labeled as critical race theory, or understanding race, racism, and basically how things led structurally to inequalities in our various systems and structures, has pretty much been banned from education for K through 12. And so a lot of times this can be confusing because, you know, prior to a year or two ago, I don't think it was as widely known what critical race theory was. And so now for it to be something that's appearing in legislation, a lot of school districts are even struggling with how do we talk about, you know, racial equality, and how do we talk about our racial equity policies, and how do we speak about the difficulties of what has happened in history, things that are statistics and facts, and, you know, and teach activism without, you know, it considering as dipping into this legislation. So it puts mental health professionals kind of in an awkward boat in terms of even how do we, you know, educate the next generation and advocate for, you know, K through 12 to also understand, you know, the history of what has led to where we are today. You're still muted, Kirsten.
I got it. Social workers' ethical responsibilities as professionals. 4.02 discrimination. Social workers should not practice, condone, facilitate, or collaborate with any form of discrimination on the basis of race, ethnicity, national origin, color, sexual orientation, age, marital status, political belief, religion, or mental or physical disability. So just going into a little bit of what kind of she just mentioned previously, yes. And then the final one that I was just going to bring up really quickly is the social worker's ethical responsibility to the broader society. In section 6.01, it states that social workers should advocate for living conditions conducive to the fulfillment of basic human needs and should promote social, economic, political, and cultural values and institutions that are compatible with the realization of social justice. So just kind of bringing in what we talked about a little bit earlier, how, you know, the basic needs of everyone need to be met in order to fill kind of the mental health crisis that are being needed to be met as well. And then the social worker's ethical responsibility to the broader society. In section 6.04 under social and political action, it states that social workers should act to expand choice and opportunity for all people with special regard for vulnerable, disadvantaged, oppressed, and exploited people and groups. Social workers should act to prevent and eliminate dominations of exploitation of and discrimination against any person, group, or class on the basis of race, ethnicity, national origin, color, sex, sexual orientation, age, marital status, political belief, religion, or mental or physical disability.
So let me also add that I know sometimes in mental health world, at least for myself as a social worker, and those that may be outside of mental health, one of the things to notate is that in Texas, there are 3 different licenses that do require a master's degree, the 2 years of clinical supervision, basically to independently practice and see clients for individual counseling. And so that's social workers, professional counselors, and marriage and family therapists. And while our education may all be similar in terms of working with clients, advocating for clients, et cetera, we do have different ethical codes. And so sometimes I know on the social worker side, we get accused of being political, and it's by no means trying to choose a political side, but we have this in our code of how we are supposed to expand choice and opportunity. And so sometimes the way that we apply these things does involve in political activism. And sometimes it may lean towards one side or the other. And again, it's not that we're trying to choose or get political in a sense, but we are trying to encourage justice. And so as a comparison, I'll kind of let Kirsten go over the LPC ethical guidelines and how that's similar or different.
Yeah, so I realize that everyone here is not a social worker, so we wanted to pull some ethical guidelines for from some other places. So as far as the LPC ethical guidelines in section 681.41, it says that a licensee may take reasonable action to inform medical or law enforcement personnel if the licensee determines there is a probability of imminent physical injury by the client to the client or others, or there is a probability of immediate mental or emotional injury to the client. The licensee must take reasonable precautions to protect the client from physical or emotional harm resulting from interaction within a group or individual counseling. And so we wanted to include this just to kind of bring up the conversation or the thought of, how does a professional then keep a client from harm, then while also understanding that a wellness check could lead to trauma by the police.
And by that could lead to trauma. Some of it could be because of past instances, whether it was an instance of discrimination and being what they felt was stopped unfairly, as we see is higher rates with communities of color. And that is actually happening. It's not a perception, but that happens more frequently, and so wellness check and then seeing the trauma that gets caused in communities when there is a shooting of an unarmed Black individual and how that lasts for days and months. So definitely drop your comments in the chat, both on Zoom and Facebook. What are the things that you see as kind of the ethical difficulties with trying to promote the well-being and mental health of your client versus, what is mandated by the code versus also the trauma they may experience. So just to look at, one option of how to help a client be kept from harm. I saw one of you in the chat kind of mention about a collaborative model, and we're going to share about another state's way that they did that.
Think about the heroics that we see from everyday patrol officers on duty in their jurisdictions and the incidents that we capture on video. We can't move forward without understanding history, or we might be doomed to repeat it. Today's contemporary police leaders need to be willing to adopt best practices and new ideas. We have to partner with our communities to break barriers. As we jump into the discussion tonight, I want you to think about someone you know who struggles with mental illness. While we're talking tonight, I want you to keep their face in the back of your mind as we talk about this new community issue. Mason City, Iowa, sits on Interstate 35 in north central Iowa, halfway between Minneapolis, Minnesota, and Des Moines, Iowa. We're a community of 28,000 people. We're blue collar and we're proud of it. We are the hub for 9 counties in North Iowa, and we are the central large city for that region. We have a large hospital, we have a large retail presence. We're also home to most of the mental health providers for that North Iowa area. Most law enforcement agencies across the United States use some sort of call for service measure as we measure statistics. Sometimes it's the demand for police services. Sometimes it's how busy we are and what we're doing. We track different things that we do this way. What I have for you for the data set on the screen is calls for service at the Mason City Police Department for welfare checks from 2012 to 2018. I want you to pay particular attention to the year 2014, 2015, 16, and 17. You'll begin to see the uptick in welfare checks that we experienced as a department during that time. Mental health response from a public safety standpoint is not a fast call for service. Sometimes these are calls that can take hours for officers, and sometimes it's multiple officers, depending on what we're called to. I want to try to put in your mind a cost on this for us from a public safety standpoint. If I have 2 patrol officers that respond in separate vehicles to a call of a person in a mental health crisis, that cost to me is about $85 an hour. If the officers get there and they discover that we need an ambulance because there's some sort of additional medical or mental health issue that we need to use the paramedics for, those 2 firefighter paramedics and the ambulance are another $105 an hour. If we end up going to the emergency room, which we do in many cases, that's $1,800 for at least the diagnostic triage of the problem with the patient that day. That's $2,000 that we've spent in hour 1 treating a mental health situation. You might ask, who cares? How does that affect me? We're all taxpayers of some kind in this room. And in our communities, public safety response is funded from general fund dollars. And so those costs are directly passed on to our taxpayers. We also don't do a lot of great follow-up in the traditional public safety response to mental health when someone's done at the hospital. We take them there, they're triaged, they're treated, and they're released. And then they go back into the same environment they were when we found them. I don't think it's a surprise to anyone that calls for service continue to go up. We don't communicate well in that system traditionally. The hospital isn't talking to mental health providers about who was there and what happened with them. So there's no safety net, there's no support system to plug them back into. A lot of times law enforcement, we walk into all kinds of unknown situations with people who are in mental health crisis. Our actions sometimes are driven by their actions. And sometimes that ends in personal injury or death for the patient or for an officer. And we also tend to criminalize mental health from the standpoint that mental health patients typically don't have a lot of resources. And sometimes the easy solution for the police is arrest for things like public intoxication, criminal trespass, or minor theft. So is this the best approach? When I got to Mason City, I learned about this problem and we began to study it a little bit. I drew on my experience of nearly 20 years with the Ames Police Department right here. We had experienced a similar phenomenon in years prior to this with an increase in calls for service. During that time, our approach had been to assign a detective part-time to follow up the day after a patient went in for mental health treatment at the hospital. We weren't always successful, but we were at least trying to start the dialogue with people in the community who could make a difference. Eventually, that position morphed into someone regular part-time and nearly full-time, following up in a mental health advocate role and trying to impact the overall outcomes for mental health patients. In Mason City, when I got there, I didn't have the ability to do that. There weren't resources available to me. And we were already having a community discussion about what this solution might look like. That led to a discussion with County Social Services. County Social Services is a 22-county consortium in North Iowa, in North Central and Northeastern Iowa that provides funding to mental health patients and those with disabilities who can't provide for their own resources on their own. The discussion that we had very quickly turned to outcomes and how we might be able to work cooperatively to impact that. Before long, we had a 2080 agreement, which is an intergovernmental cooperation agreement to employ a justice coordinator at the Mason City Police Department, but funded through County Social Services. The justice coordinator was a new position, and the idea here was that this was a social worker who already sat behind the HIPAA wall. For those of you that aren't familiar with what HIPAA stands for, it's the Health Insurance Portability and Accountability Act. It protects all of our personal medical information so that people can't get to it and it can't be shared. It is the exact barrier that kept us from having success in outcomes for mental health patients. So the idea was that the justice coordinator would start with the communication piece. When a new name came across her desk, she would start to reach out to our mental health providers in the area, to the hospital, and to other people who might be able to point us in the direction where this person was already plugged into services. Once we're able to determine that they were plugged into services, the justice coordinator follows up with the care. What are we doing? What's not working? What are the other things that we can try to put this patient back into a living situation that works for them, but keeps them out of crisis? Unfortunately, a lot of times, mental health patients don't have resources. And so at times, the justice coordinator becomes their only advocate. And we work to try to find good placements for them and to help them make good decisions about their care and what that looks like. We couldn't do this alone. We had to have our whole community behind us to make this work. I told you that that conversation was already going in Mason City before I arrived. And we had good cooperation from our local community to do that. That included our hospital and the emergency room, which was our primary stop for psychiatric triage, and then placement after that. We had all of our mental health providers in the community come to the table and say, yeah, we're in. We want to help you do this, and we think we can do better than we're doing right now. And finally, we brought a federally qualified health center to Mason City. This is a facility that provides care to people who typically don't have it, those who can't afford it, or those that don't have access. Think of people maybe coming out of jail or incarceration, those other kinds of places where they don't have insurance, and they don't have any way to get medical care, mental health care, or dental care. We brought that clinic to Mason City, and it opened last October. They've since seen 2,400 new patients, which is filling a huge gap in our community. We also continually to meet regularly as a group. We talk about what works, we talk about what doesn't work, and we talk about staff changes, and we have to keep having the conversation to make sure that we're all on the same page. And finally, in 2017, we applied for and received a mental health planning grant. That was an opportunity for us to write a plan for a community mental health response that helps to improve outcomes for patients. One of the things we learned as we were completing our grant application was we had some communication issues. Sometimes these were as simple as an officer bringing a patient into the ER and not sharing all the information they needed to with the triage nurse to get this person appropriate help. Sometimes it was jail staff who would lose communication with the patient when they were discharged from jail, and we couldn't get them referred back into community services. Sometimes it was a complete breakdown between the hospital and a provider. So we worked really hard to look for solutions to that problem. And the biggest thing we were able to do was come up with a release of information with all of the parties in the discussion on it. That release can be started at any point in the process now by any group, any entity, or the patient, and can be shared so that we can share information across those lines. It has worked very well for us to start to share information. Before we talk about results, I want to point you back to the data set that I started with. I want you to pay particular attention to the difference between year 2017 and 2018. And I think I can point you in the direction of why those numbers are starting to go down. I'm going to talk about 3 cases tonight. The first one is Joe. Joe landed on our radar in Mason City in November of 2016. Joe was homeless and disabled, obviously disabled. And our department received 19 calls for service over 4 weeks related to Joe. At the time, we were just getting ready to start the mental health or the justice coordinator program. And so I happened to be heavily involved with this one, with our justice coordinator at the time. We worked to offer Joe every program, every service, and every resource that we had in Mason City as an option. Trying to get him placed before it really got cold in the winter, trying to get into a place where he would have food. Joe was very, very proud. He was homeless, but you wouldn't know it. He was always clean. He always took care of himself, and he was never a danger to himself or to anybody else. Joe ended up rejecting all of our offers for help. We were able to finally get him a bus ticket back to a community where he'd lived before. He wanted to go back to the shelter there. We did that. Think about the heroics that we see from everyday patrol officers.
Sorry, that started real quickly. But yes, looking at basically how they partnered together and what the outcomes are is really, really important. You know, one of the things, I won't steal the show from Kirsten on this one, but so Kirsten, tell us about GAP, and then I'm going to add in some comments about how important it is overall.
Yeah, so like we talked about the video a little bit, obviously that is just one intervention for one specific community that worked well for that community. But kind of when we were assessing the gap in our own community in the Arlington-Fort Worth area, we were trying to kind of figure out how we can best fill in that gap, which was how we came up with the GAP program, which stands for Greater Access and Partnership Program. And so our initiative works alongside with local law enforcement to help bridge the gap between individuals in need and the resources that are available for those individuals. So our hopes in doing this is to create some sort of long-term crisis resolution that includes case management, counseling, and a coordinator, which is currently me, or another community liaison. And so through this program, we aim to hopefully help reform the process of crisis management and create a positive image of law enforcement to help reduce the cycle of repeated interactions between local police and community members. So kind of right now, how our system has been working is when a police officer or a law liaison will go out onto a call with a client that is currently in the middle of a mental health crisis, they'll then send us a referral to them. And so then it's our job as a GAP coordinator or community liaison to then reach out to that client that's been referred to us and not only help them with case management to basic, and we also help them with basic needs and other resources, you know, such as maybe financial, housing, food. We help them with all of the basic needs like we discussed earlier to then help them with the greater issue of the mental health need to hopefully result, you know, in them then being willing to go to counseling or whatever they need to address that mental health concern with them. And this is something that we've implemented in our community. And like I said, the video was something that was implemented in another community, and definitely want to acknowledge that kind of what is working in our community may not necessarily work across the board, but this is what we've done and what we've kind of started that we find is working and is helpful in our community.
And to jump in real quick, because I did see some comments come into the panelists, both checking in from some of the different programs as well as asking about it. But to break it down a little bit, right, what used to happen, which is what the police officer expanded a little bit, is that people call 911, even if it's a mental health emergency, and police officers were the only ones to really go out and respond. Now we have seen partnerships start to pop up using a model that's called the sequential intercept model. So those that are in law may be like, hey, we know that one. And the idea is basically, how do we stop from getting all the way to jail? Because the more and more issues that pop up is the more likely that prison or jail are an end result. So currently I know in Tarrant County area, and it looks like I saw a check-in from Denton County area as well, experiencing the same thing, where there are partnerships with the local mental health authority, and they have what we call law liaisons, and they're the individuals that are actually employed by the mental health agency, and they write out with officers to help basically reduce the crisis in that moment. So that is amazing. And we need that because, again, why are we calling police for a mental health emergency and not a mental health professional? Now, the difficulty that we found is what happens after that? How do we keep from even getting to that point? So it's not that the program is not working. And these are called the crisis intervention teams and I believe the community response or crisis response teams. So sometimes they're referred to as CITs or CRTs. And again, that's helping for those first two steps, but you have individuals across the entire spectrum of sequential intercept model, which I'll send out with the email, that basically either they are leaving jail or maybe they've offended before or they're on probation or parole. And how do we try and get all of these different systems to work together we're not continuing to have this crisis over and over again. So one of the ethical responsibilities, and then you jump in, Kirsten, is, we've talked a lot about social justice and advocacy. And that is basically to change the system, because we've still seen limitations in how we are communicating with one another, and how that's affected, even being able to get care after an individual does step down from crisis, or if they're not able to resolve the crisis in that moment and do have to be hospitalized, what happens then, and how do we overcome the barriers of HIPAA? So, Kirsten, any additional thoughts on that one?
Yeah, I just wanted to say that this program definitely took some time to develop, and it has been kind of put in place for a little while now, and we're still continuing to grow and learn with kind of the things we learn while we're just out in the community doing it. And so, no matter what we're trying to implement in the community, I think it's just important to note kind of like all the small wins that he was kind of talking about before, how you might not see some major turnover or statistic changes overnight, but that the fact that you are implementing something or trying to change something within the community can kind of be the win in itself, as to more than just discussing the statistics that we kind of keep bringing up over and over again. And so we just kind of wanted to open up the floor if anyone wanted to share, some ways that, you feel like you can advocate on behalf of the population that we've discussed, or ways that you are currently doing it, or any ideas or anything that anyone might have to do so.
So while you guys submit your comments on Zoom or on Facebook, for those that are watching live, just about ways that you want to advocate and kind of carry this information forward, because statistics, education are not enough. It takes implementation. One of the other things questions I saw come in is, how does our program help create a positive image of law enforcement, and where's the ownership in that? So the ownership in that is the fact that they are referring and working with us, so that interactions with police do not have to be negative. So they are doing the hard work, and we are just partners in creating change. And so I know we've had different instances where, like I said, the crisis could not be reduced, and maybe an individual had to be hospitalized, or maybe there really was a crime committed and they were temporarily jailed. But because we're able to continue that relationship of, hey, law enforcement is sending me out to help you with basic needs, to help you succeed, because they want to see you do well, and law enforcement is out there with us, I would say that's where we've seen the positive effects, where people are more willing to communicate because it doesn't always end negatively. I saw another comment come through real quick that talked about looking at that sequential intercept model, which really, there's so much that we could have covered. So I'm sorry we didn't add that in. And really said it great about it's bringing together stakeholders to create meaningful change, brainstorming, looking for solutions, especially for those that are most recidivistic. Very nice.
Yeah, and I would throw out, so as we get started with the big conversation of kind of where do we start, macro and micro. So macro meaning big, micro meaning tiny. And I always, macro level, the big level, I always come back to voting. So at the end of the day, we as a society decide what's important by putting the budget together. And you value what you pay for what you value. And if we truly value mental health, if we truly value law enforcement and everything in between, we need to put our money where our mouth is. And the way that we do that is by voting, but more importantly, you hold the people who are whose job it is to manage that budget. We hold them accountable. And so make sure you vote. And then on the micro level, what to do? Well, this is a lot harder, because if you don't know where your blind spots are, you're going to have a problem. And when I say blind spots, everybody has a measure of things that they don't see very well. And depending on your level of privilege, which is kind of the ability and the and the gift of not having to see certain things or to live certain experiences, you may be missing something. So you may not understand that Black folks are suffering in a particular way, or the LGBT community is suffering in a particular way, or people experiencing homelessness or severe mental illness are suffering in a different way. And so this is a call to action to kind of watch your personal actions. Where are you personally spending your time? Where are you personally spending your money? Where are you individually putting your energies? Because if it's not to aggressively tackle these things, they're going to continue to happen, even though we have all these brilliant, amazing people in this workshop. If you don't personally go and change some of your own behaviors and attitudes, we're not going to get very far. So that would be, as we open up that discussion, as a psychiatrist, as a Black guy, as a Texan, that would be my call to y'all is, number one, vote on the macro, and then learn your blind spots on your micro.
I like that. The other thing I would really talk about or ask you guys to think about is, I think we have a lot of agencies that are doing amazing work. And I know one of the things that we have really tried to promote as a part of mental health connection meetings in Tarrant County, woo woo, shout out to y'all, is that there's not a competition as mental health providers. That while we may be what's considered a service-based industry, it's very weird to think that we shouldn't collaborate because we might miss out on something. And so we need significantly more collaboration. I think the other thing that's really important is there's a funding need. We can have all of the intention and all of the people, but I know we have been very direct in talking about the GAP program, and we had funding for it for a year. It was a pilot program that originated out of we continually seeing negative interactions between community members and police, between persons of color and police, and asking, how do we get to the root of the trauma and make a difference? And the reality is we're coming up on a year. And so if we don't have funding, I know one of the questions, since we work so closely with Arlington Police Department, they've said, well, where do we send people if GAP isn't there? Who does fill that gap? And I don't know the answer to that because as we've discussed, there are difficulties with access to care. There's a limit on mental health providers. And so these are all very good questions where we need all of our agencies together. So to kind of give you guys some closing thoughts, we are technically scheduled through 11:30. So keep sending the questions, thoughts, comments, challenges in, but I do want to make sure that we add some of these things. So after the workshop, we will open up the Google form for those doing the CEU. We will also send links to different handouts and videos so that you can review this information. I know we showed some videos that were clips from larger conversations about racism and discrimination and how that's affecting communities of color as a whole. And so that's where we have to, like Dr. Dixon said, we have to check ourselves, check our knowledge, do our own research to make changes. And so I hope that this will be the beginning of a conversation for whatever role that you fill, whether it's mental health professional, police, basically working in law, or maybe you're just an interested, curious community member. All of those things are equally important in making a difference. And we all have a role to make in creating change. So we'll send you the links and handouts that'll come from Eventbrite for those that signed up there. If you didn't sign up there, I think there's a link on Facebook. So if you're seeing this, you saw us go live, you can click on the event, purchase buy tickets or something, and I think they're all free. And that way you get all the messages about it. We also have another upcoming training, and that one's October 14th, and it's called Supporting Client Goodness, remember I said up all night. So supporting client autonomy for care workers. And it's led by Jen Sardoui. And apparently I also did not finish my sentence. And she's a V radical. And they do a lot of really good work, and we have to keep having the conversations. And so we do have some important fundraisers. So the t-shirts we showed at the beginning that had the awesome mental health quotes about mental health for everyone, and that we all play a part in fighting injustice. We do have those for sale, and we'll send you some stuff. We have North Texas Giving Day. And again, these conversations were not even possible because where do you fund the time and where do you fund the people and the resources to do this unless it was for the Fund to Advance Racial Equity at the North Texas Community Foundation. So we're extremely grateful that they saw the need and that they built on the need, and that we were able to be a part of their second year of doing grants. And so we have more workshops to come. So from my co-panelists, what else have you seen come in, or what other things have we not mentioned?
I'm not on Facebook. On my end in the chat, I haven't seen any other questions come in, but I think you kind of did a good job of wrapping up things that we've discussed. I know we kind of hopped around from topic to topic, but I hope in the end we're able to kind of bring it together for you to show how everything that we discussed connects to what we're hoping to enact the change in our community to do.
Yeah, and Stas, all I would add, I go out often and I give talks about mental health and how to access mental health. And one thing that I've added recently is a sports analogy. So I'm not a sports guy at all. I play tennis and volleyball, which are, you know, not the most popular sports in Texas. But when I'm talking about Dallas Cowboys football, and I think, again, I think we have some folks from Atlanta, so go Falcons, right? When you are at a football game and you're watching the game happen and you're enjoying yourself, there's so many aspects that go into making that possible. There's an entertainment infrastructure that makes that one action possible for, you know, Dak Prescott to throw the touchdown and for everybody to cheer wearing your Dallas Cowboys regalia. And in mental health, so, and if you think about it, you know, you have to have players, you have to recruit the players, you put them through the gauntlet, you have to have uniforms, you have to have vendors for food, you have to have engineers to build the building, you have to have marketing. I mean, it's this huge infrastructure. And when you think about it, it's very transparent. And if you know the system, you know how to work in the entertainment industry. Well, the same is not true for mental health. So in mental health, we're here, but you can't always figure out who does what and who is where. And so we know that from the mental health side of things, we have some work to do to make sure that our infrastructure is in place so that then when law enforcement or education or any other sector needs us, that we can be there. And so this presentation is not pointing fingers at any one particular industry. It's pointing fingers at all industries because we're all behind when it comes to making sure that we integrate mental health into everything that we do. So we just appreciate y'all being here, and I appreciate ACFS for what they're doing.
Thank you for those kind words. So yes, just to emphasize some final closing thoughts on that. I mean, if we as social workers are struggling to find the resources for clients, and we're struggling to navigate who has the right opening to get mental health treatment that's local, especially when many of our communities do not have transportation, and how do we get them stable to know that their food is taken care of, then I can imagine how living in a state of trauma or having untreated mental illness, how significantly more difficult that is. I also understand how officers are put in an impossible position. That doesn't mean we defund them. That means that we look for more creative solutions, and that we all have a part to play, both to collaborate and to discuss and to release information into police have a part in referring to agencies such as GAP, so that there is a difference, because otherwise we've seen that the same structures have ended in the same sad results. So what we were doing is not working, and that's where we have to enact change on this. We have to be able to think outside the box and look for how do we expand even the mental health professionals that we have in Texas? So a whole separate talk for another day. Anyone who knows me, ask my feelings about credentialing and mental health providers and the shortage in Texas, because basically we have a system set up for failure where it's not getting better, because all of these things that we discussed and that Dr. Dixon, really pointed to, they are structural issues that are broken. And so we have to get our structure together. I won't say so that we can perform as well as the Dallas Cowboys, but so that we can be the best of the best in all that we do. So we will close it out early. If you think of questions or comments that maybe you did not feel comfortable sharing, you have our contact information. We'll be sending you stuff on Eventbrite. So again, thank you all for joining us today. And we hope that this will be the start of many deep and wonderful conversations and enacting change to come. Thank you.
Thanks, y'all.